All right. Can you guys hear me okay? All right. So thank you so much for inviting me here. I'm honored to be here to talk to you guys about something I'm very passionate about, ventilator management on ECMO. This is very controversial. So I tried to make it very practical, okay? Because there's a lot of evidence, there's not that much evidence out there, and there's a lot of opinions. But I'm trying to make this lecture as practical as possible for you guys. So special thanks for Dr. Owens, who's my mentor, and Dr. Palema, who's the ECMO director at UCSD, and Cassia and Michelle, who are the ECMO coordinators. I have some disclosures. I work for ELSO, which is the International ECMO Organization, as an educator for them. I go to other hospital systems and train them on how to do ECMO, nurses, RTs, physicians. I do have NIH funding that's pending. Who knows what will happen with the NIH on ventilator settings with VV ECMO. And then I do consult for ECMO companies. So learning objectives today. We're going to talk about the ventilator settings when you're on VV ECMO for ARDS. We're going to talk about we're going to talk about ventilator settings when you're on VV ECMO for lung transplant. And then what happens when you're on VA ECMO? What do you do with the ventilator? What happens when you have VA ECMO for a patient with ARDS? What happens, and then how do you titrate the PEEP for VV ECMO? And how do you titrate the PEEP for VA ECMO? So a lot of things to talk about. Luckily, you guys already we're already educated on ARDS. And so ARDS, you guys, just to go briefly through it, it's common and deadly. We all see it. 10% of patients in the ICU. Severe ARDS has a high mortality. 50% of patients will die. It's a syndrome. All right, there's two types of ARDS, which you guys already got told about, non-intubated ARDS and intubated ARDS. And we rate ARDS based on the severity. How bad is the hypoxemia? And we're going to basically focus on patients with severe ARDS today, because it's an ECMO lecture. So hypoxemia does not kill patients with ARDS, all right? It's how we grade it. But what happens is in ARDS, you have lung injury, all right? You put them on a ventilator. The ventilator can cause more lung injury, called ventilator-induced lung injury. That injury causes inflammation, and then your lungs get the whole blood supply, which means all the blood in your body picks up that inflammation, and takes that blood to the rest of the body. So then what happens? You get multi-organ dysfunction and then eventually failure. You learned about delirium. Delirium is brain failure. ARDS patients, they get kidney failure 30% of the time. You get cardiac failure, they're on pressors. And multi-organ failure is how you die from ARDS. It's not hypoxemia. So how do we break this cycle? We try to minimize ventilator-induced lung injury, decrease the inflammation so you don't go into multi-organ failure. All right, so even healthy lungs without ARDS can get damaged, okay? And so if you put a patient that's healthy on a ventilator, if you have injurious ventilator settings, you can hurt those healthy lungs. So that's where low tidal volume ventilation comes in. So most of you in this room are RTs. And nurses, you all know that low tidal volume ventilation is standard of care for all patients, okay? Even if you don't have ARDS, you should be doing low tidal volume ventilation. And what does that mean? Well, you give the ventilator a setting. Usually it's a mixed mode or volume control. You can also use pressure control. And you set a tidal volume, or your goal tidal volume is 4 to 8 cc's per kilo of ideal body weight. Everyone always says 6 cc's per kilo. It's obviously a range, 4 to 8. But if you put 6 in your head, that's fine. All right, the respiratory rate, we titrate it for the CO2. We always want plateau pressures less than 30. How to titrate PEEP? Oh my God, this is a huge topic, right? Well, it's based on many things. Hypoxemia, you can do PEEP ladders. You can base it on your body habitus. You can do other things like esophageal balloons and EIT. Those are more experimental. All right, so there's many ways to titrate PEEP. And then finally, FiO2, we always try to minimize it so long as the SAC goal is within your goal. Usually with ARDS, it's 88. So low tidal ventilation saves lives. That was proven in the ARMA trial in 2001. All right, and then in 2013, the PROSEVA trial came out showing that also proning saves lives. If any of you guys are taking care of patients with COVID, we were proning all of them as we should have. So on this graph, we're showing the survival curves. On the x-axis is days. All right, on the y-axis is probability of survival. Look at that. The prone group had a much higher probability of survival, 0.8, compared to the supine group of 0.6. So low tidal volume ventilation and proning saves lives. We also do dry lungs or happy lungs. We diurese them, and we keep doing that with ARDS. So what other therapies do we have for ARDS? We talked about low tide volume ventilation, proning. There's helpful things, but the survival benefit may not be there, but we use neuromuscular blockade, which is controversial due to the ROSE trial, which someone else will actually talk to you about today. High PEEP in meta-analysis may be helpful. Steroids for at least COVID pneumonia, but it may be helpful in other types of ARDS. Dry lungs or happy lungs, and VV ECMO. All right? Things that don't work and are harmful for ARDS, APRV, that ventilator setting, because the pressures are very high and people can spontaneously breathe on it. INO is a rescue measure that can help with hypoxemia. And recruitment maneuvers, high pressures for about 30 seconds to open up the lungs, have been shown to increase that inflammation. And as I've already said, that inflammation goes to the rest of the body, and that causes you to have more multi-organ dysfunction, and that results in death. So our learning points for now: ARDS is common and deadly. The ventilator may cause harm. All right, low tide ventilation decreases that harm. All right, and there's other things that may help decrease mortality and be helpful in ARDS, and that is proning, high PEEP in meta-analysis, neuromuscular blockade, possibly, and dry lungs or happy lungs, and then finally VV ECMO. This is a picture of a patient being proned, all right, and he's also on ECMO at our institution. His SAT's way too high, it's 100. Remember, 97 is the new 100, guys, all right? All right, VV ECMO provides respiratory support, and the goal is for either recovery or transplant. All right, so just basics. You have a drainage cannula, usually 25 French, about the size of my finger. They're 55 centimeters in length. We put them in the femoral vein. All right, we usually put the tip of them right in around the diaphragm. Sucks blood, goes to a centrifugal pump, which sends it to an oxygenator. This oxygenator acts like the lung, puts in oxygen, takes out carbon dioxide. All right, and then we pump that back into a vein, all right, for VV ECMO. So why there's a dash here, it's V, where you drain it from, the vein. Dash is the oxygenator, and then the next V is where you return to a vein. If I was returning the blood to an artery, it'd be V-A. All right, and you can return to multiple veins. You can also return to the other femoral vein, etc. So the ventilator strategy when you're on VV ECMO is different depending on what your goal is. Is it recovery or is it transplant? So for VV ECMO for lung transplant, when we're bridging patients, every time you put someone on ECMO, we got to think about how are we going to get them off ECMO? What is our bridge to? Where are we going? We're either going to recover them, or we're going to try to get them to transplant, or sadly, sometimes it's a bridge decision. We don't know if they're going to die or not, or we don't know what's going to happen. All right, so, but most of the time, we're trying to get them off eventually off ECMO. So as a bridge to lung transplant, all right, the ventilator settings, we don't change them. We still do low tide volume ventilation. Why? We're still protecting the lungs. There's another ventilator setting that I'm going to talk to you guys, which is ultra low. All right, but we use just regular ventilator settings when we're trying to bridge them to lung transplant. The reason why we don't liberalize their lungs, because you say, who cares about the lungs? They're going to be cut out and thrown out, right? But you can actually damage their lungs that they already have in their body, and that can cause barotrauma, such as pneumothoraxes or hemothoraxes. That results in pleural disease, and it makes it harder for our surgeons to cut out those lungs. So we still rest their lungs a little with low tide volume ventilation when they're a bridge to lung transplant. But sometimes when you're a bridge to lung transplant, no ventilator is better. What's better than a ventilator? No ventilator. We can try to extubate them. We put them on ECMO, we extubate them. All right? Because the whole goal once we put them on ECMO is we wake them up and walk them. And we've published that when you put them on ECMO as a bridge to lung transplant, you really want them to be able to walk at least 150 feet, at least, to get them to lung transplant and have good outcomes. All right? If you can't extubate them, early tracheostomy so we can wake them up faster, okay? Other things we can do, we already talked about wake them up and walk them after we put them on ECMO, again, because we're trying to get them to transplant as quickly as possible. We want to try to minimize blood transfusions. We use pediatric tubes. We only do labs as needed. We cancel all the labs we don't need. We always use a BAMP so we don't waste blood. We follow iron levels, and then we walk them. So here's a patient at our institution who got lung transplanted. Let's see if this works. Oh, there it goes. So you guys have all seen this, the guy playing basketball. It's nothing special. We try to walk about most of our patients. So, you know, when patients, he's on ECMO, you can see his return cannula there, you can see the ventilator here, he's trached. We weren't able to fully extubate him. So this gentleman was walking, I think he got to like 800 feet. Our goal was, our max so far is someone got to 5,000 feet, and we had to stop him because the nurses got a little annoyed, which I get it, all right? That's a lot. So we PT our patients, we get about 60% of patients that we can actually eventually PT on ECMO. On VV ECMO. So now let's switch. We're going to go, we just talked about ventilator settings for VV ECMO for bridge to lung transplant. You can either extubate them or do low tidal volume ventilation. Now let's switch. We're putting them on VV ECMO for ARDS with a goal to recover their lungs. We don't want to transplant them, we want to recover. So I already told you low tidal volume ventilation, all right, is helpful. It's a survival benefit. It's one of the few things that decreases mortality in ARDS. So if 6 cc's per kilo is good, what about 1 cc per kilo? You know, what about the driving pressure? If it was at 20 or 15, what happens if we go down to like 10? So how low can you go with VV ECMO? Because the nice thing is now we could do tidal volumes or driving pressures that are so low that no patient would ever survive without ECMO. But nice thing, you have ECMO now to take over the oxygenation and CO2. So just very quick background. I know you're all RTs. All right, so this is what is the driving pressure and tidal volume. Just remember, the driving pressure is a measure of the pressure needed to deliver a specific tidal volume. If you decrease your tidal volume, it decreases your driving pressure. Opposite, if you decrease your driving pressure, you also decrease your tidal volume. They're related. So if you look at this graph, this is the x-axis. You guys can't see my thing, sorry. So if you look at this graph, here's the x-axis right here. All right, this is time. On the y-axis is pressure. You're taking, you have PEEP here. You start inspiring, so they take a breath. The ventilator cycles on. They take a breath, peak pressure. Then you get a little plateau. All right, and that's your plateau pressure. And then you go back down. You cycle exhalation, and you go back down to the PEEP again. So your plateau pressure minus your PEEP is your driving pressure. That's the pressure you need to get a certain tidal volume. All right. How does pulmonary compliance change the driving pressure needs? So if you have severe ARDS, okay, think about it. The compliance of your lungs are now filled with pus and fluid, bacteria, virus, whatever, all right? It's filled with all that inflammation. The compliance is really, really low, all right? The lungs are stiff, which means to get the same tidal volume, you need a higher driving pressure. So compliance, if you must know a number, the normal compliance of the respiratory system is 100 mLs per centimeter of water. You don't need to memorize this. What you need to understand is the concept. If the compliance decreases with ARDS, because the lungs are stiff, filled with fluid and pus, you need more driving pressure to get the desired tidal volume. If the compliance increases, you get a patient with emphysema, COPD. The compliance, now that balloon, instead of being really stiff, now it's floppy. All right, you need less driving pressure to get the tidal volume because you need less pressure to open up those lungs and get that tidal volume. So that's how compliance changes the driving pressure needs. All right, why am I talking to you guys about driving pressure? I have to show you guys one study. All right, this study by Amato, published in New England Journal, all right, basically showed that patients with low driving pressure have a survival benefit in ARDS. All right, so this graph, x-axis is centimeters of water, all right, and that is your driving pressure. That's the x-axis. On the y-axis here is your relative risk of death. You want to be less than 1. You want to decrease your risk of death. So look, here's 1. Right when the driving pressure gets less than about 15, around 10, 12 right here, your risk of death decreases. So this is really important. Low driving pressure probably decreases your risk of death in ARDS. So why am I teaching you guys this? Is because this was realized before this study came out, that when you put people on ECMO, we have now the ability to rest their lungs even further, all right? So in all patients with ARDS, we do low tidal volume ventilation, and that's what we already talked about. But when we're on ECMO, we do low driving pressure ventilation. What we do is we set the driving pressure, not the tidal volume. It's not 6 cc's per kilo. We just set the driving pressure. Well, what do we set the driving pressure at? Usually it's just 10, because you saw in that last graph, patients with lower driving pressures have decreased mortality. What do we set the respiratory rate? Well, the ECMO circuit's pulling out the CO2 for you, so you don't need to have a respiratory rate really high like you had on that ARDS patient. Instead of being like in the 20s, 30s, ELSO recommends 4 to 15, low respiratory rates. What happens to your PEEP? Well, your PEEP is variable on low tidal volume ventilation. You do it for many reasons, which we already talked about, hypoxemia, body habitus. When you're on ECMO, a lot of times the guidelines say just 10 or above. So this is where 10, 10, 10 comes from. 10, 10, 10. Set your respiratory rate at 10, your driving pressure at 10, and your PEEP at 10 with a pressure control setting. And that is the most common ventilator setting across the world in large ECMO centers. All right? And that was based off of like the lifeguard study and stuff like that. Also EOLI, which they did something very similar, had very similar ventilator settings. Basically, they want the plateau pressures less than 25, set your rate at 10, your PEEP at 10, and your driving pressure at 10. Now, this is a shameless plug. I think this is very simplistic for all our patients. So we're saying one ventilator setting for all these ARDS patients, and this is what my research is in. What should we set the ventilator setting? It could be more personalized. So that's what my research is in, specifically PEEP. All right? So this is one of the important slides on here that I want you guys to know about. The 10, 10, 10, low driving pressure ventilation on VV ECMO for ARDS. I already kind of told you guys, like the driving pressure and the tidal volumes depend on each other. So if the ARDS lungs are very stiff, they're non-compliant, and now you put a low driving pressure in there, right? Your driving pressure might have been 20, 25 on low tidal volume ventilation. Now you put them on ECMO, and now the driving pressure is much lower, it's 10. What do you think happens to their tidal volumes? They get smaller, all right? We have seen tidal volumes of 0, tidal volumes of 10, essentially apneic ventilation, all right, on these patients. What do you think happens to X-ray? Well, this is pre-ECMO on the right side. Oh, sorry, your left side. And then you put them on ECMO day 1. Look at what happens to the lungs. Completely collapse down, all right? And then with time, they stay collapsed, and then with time, they slowly start getting better. This is day 12. You can start seeing lungs again, all right? And then, he got pseudomonas pneumonia, he got VAP, maybe got a little worse. And then by day 52, lungs are improving. You can see his drainage. Here's his drainage canals right here. His return canals right there. And this is him coming off ECMO. He was on ECMO for 67 days. His SATs were 70 for weeks. He required paralysis, INO, PEEP of 20, and that's just to keep his SATs at 20. That's how hypoxemic this gentleman was. But he survived. I mean, our ECMO flows were at 6.5 to 7 liters a minute, the max you can get. The reason why it's the max is the oxygenators on these ECMO circuits are rated for 7 liters, essentially, the most common ECMO circuits. All right? He actually required 2 drainage cannulas. We had to have 2 cannulas draining blood from his groin, and then we were turning it all to his neck. So he did survive, but expect these x-rays to get really, really severe, and it takes weeks for them to wake up. This is the hard part. The hard part is being patient and giving the patient time to recover. So what are the goal SATs when you put someone on VV ECMO? Well, no one really knows. The goal SATs on low tidal volume ventilation, regular ARDS patients is 88. But on VV ECMO, large ECMO centers, we tolerate SATs down to 85, 80, 75, 70. Because what else can you do to this patient? You already put them on ECMO, they're already on vent settings, on high vent settings, like with a PEEP of 20 on that last patient. What else can you do? So we tolerate the lower SATs because, again, we are trying to rest the lungs to decrease inflammation, to minimize multi-organ failure, all right? So long as they're not multi-organ failure, the lactates are normal. We follow their lactates when we leave the SATs this low. We get at least a lactate a day, all right? And we just tolerate it. It's very hard. It requires a lot of hand-holding for everyone, all right? Because this is uncomfortable to see someone sat like this. But this is different than a regular patient's SAT. If our SAT went from 100 to 70 quickly, that means something's happening acutely in our bodies and it's going to keep going down. These patients, their SATs stay at these levels for weeks, okay? Now, we do follow these patients in our post-ICU clinic because we are always trying to find is there any long-term neurocognitive outcomes, and we're going to be publishing this eventually. All right, well, what happens when you're on VV ECMO and they're really hypoxemic? What can you do? The SATs are 60, all right? Or they're 70 and you don't like that, you want them 80. What else can you do? Well, you can go up onto ECMO flows, which is the easiest thing to do. All right, go up on the flow on ECMO, not the sweep, but the blood flow. You can, and sometimes we have to add a second drainage cannula. All right, sometimes we rarely add a second oxygenator, so we have 2 oxygenators oxygenating the blood, which doesn't help that much, but we do. We optimize the ventilator. PEEP of 10 might be too low, all right, so we increase the PEEP. We go up on the FI2, but we still try to keep the driving pressures 10 to 15. We don't want to stretch the lung out so much that could harm them. Other things, you could prone them, which has a survival benefit in ARDS patients, but on ECMO, it's controversial, to be honest. I love proning, but I have to be very honest about it. In meta-analysis, proning has shown likely a survival benefit on ECMO, but the largest study, which was the prone ECMO study in COVID-19 patients out of France, did not show a survival benefit. But they only proned them 4 times. So most of the time when we prone people, we're proning them for weeks. Other things we still do, sometimes they still need neuromuscular blockade. As horrible as that is, they're on ECMO, they're so hypoxemic, they're so dysynchronous, you still need to do a little neuromuscular blockade. Rarely we do INO, rarely we do cooling, and no, we do not use beta blockade. Some centers, what they do is they'll put patients on ECMO, they're desatting, and they just drop their heart rates, so more of the blood goes through the ECMO circuit. We do not do that because that doesn't change oxygen delivery, and it may actually cause RV failure in these patients. And this is a whole talk on itself. And there's a few studies talking about this. So when you have ARDS, you have 2 issues. You can't oxygenate patients, but you also cannot take off their CO2. You have a huge dead space fraction. And patients on ECMO have the most severe ARDS, which means their dead space is really high. They cannot remove CO2. All right? And again, they have poor compliance. So this is going to be a busy slide. Oh my God, there's so much stuff on here. All right, so follow me, and I'm going to walk you through the slide. So we're going to start at the top. This is going through the whole course of ARDS. And the main thing I want you guys to realize about this thing is that when you have lungs with ARDS, oxygenation improves first, which means the lungs eventually, as they heal, they'll be able to oxygenate the body. But dead space fraction, the ability to remove CO2, takes much longer. Okay? So you'll see patients, wow, their oxygen is doing great. But the patient cannot blow off their CO2. Their dead space fraction takes a lot longer to normalize. All right? So you have someone with severe ARDS, you cannulate them. All right? So this is the first thing we do. And then if you go across the screen at the top, this is all the way to recovery. And this is when we decannulate them. And we're going to go through everything. So when we first put them on ECMO, we're resting the lungs. We want to minimize inflammation. We want to minimize their lung injury. Now, the tidal volumes are very low because we're doing low driving pressure ventilation, 0 to 50 sometimes. It depends on their compliance, but their compliance is usually low. Some patients have bad ARDS and their compliance is okay, so their tidal volumes will be like 200 or 100. All right, we don't control it, we're only setting the driving pressure. Oxygenation. The lungs are doing nothing. That's why the lungs are in blue here. All right, but ECMO is doing all the oxygenation. And what you'll notice eventually, the lungs start improving and they will take over the oxygenation, and the ECMO circuit doesn't have to do it. The lungs will do it. CO2 removal, same thing. At the beginning, ECMO circuit has to do all the CO2 removal, while the lungs are not doing much CO2 removal at the beginning. And that's why at the beginning, your ECMO flows are high, 4 to 6 liters a minute, because that's for the oxygenation. Your sweep, ECMO sweep is essentially minute ventilation. High sweep, more CO2 is removed by ECMO. Low sweep, less CO2 is removed by ECMO. At the beginning, you have high sweeps and high flows because you're taking away all the CO2 and you're oxygenating all the blood with the ECMO circuit. As they get better, as we rest the lungs and the tidal volumes are getting better, the compliance is improving, the lungs will oxygenate more, but what you'll notice is the CO2 takes longer for the lungs to recover, all right? It takes longer for dead space to usually recover with severe ARDS. So you'll see the ECMO flows start coming down because they don't need as much oxygenation. The sweeps are still pretty high. And then what will happen is eventually, we don't need much flow. We keep their blood flows at 3 to 4 liters a minute because their oxygenation is fine, but it takes us a little longer to get them off sweep to remove CO2. And eventually their sweep is 0, and that means they're off ECMO because when you're on the sweep of 0, not only are you not removing CO2, when your sweep is 0, you're also not oxygenating the blood that's going through the ECMO circuit. So you're not oxygenating or removing CO2. And then their tidal volumes are back to normal. And when I say normal, I mean 6 to 8 cc's per kilo, like a regular patient. And then, and that's around recovery time, and we'll be taking them off ECMO around this time. How long do you rest the lungs for, and until you start waking them up and starting to PT them? No one knows. I've asked the world experts on this at ELZO, and so no one knows when is that sweet point, sweet spot where you start, instead of resting them, you want to start waking them up. What we do as an institution, we do a couple of weeks of rest because we don't want them to go into multi-organ failure, so usually about 2 weeks of resting them, and then we start waking them up. But every patient is different. Some patients have very little lung injury, and it recovers quickly. E-Valley, do you guys remember that, vaping, that caused a bunch of horrible ARDS, horrible lung injury. That thing melted away with steroids within 2 or 3 days. We put 2 patients on ECMO. We were actually one of the first centers that did one, that put 2 people on ECMO for E-Valley. They were off ECMO within like 3 or 4 days. Why? The steroids melted away the inflammation. So it all depends on what the lung injury is initially. So how do you know when you're ready to start weaning patients from ECMO? Well, the patient tells you, all right? We don't decide, the patient decides. The lung compliance improves with the same driving pressure, the tidal volumes will go up. The lungs are getting less stiff. The X-ray improves. Instead of looking like this, it starts looking like this. And they aren't requiring, all the other modalities, proning, paralysis, INO, high PEEP, etc. And then when we wean VV ECMO blood flows, we always wean flows. We only wean flows to make sure that their SAT is okay, but we also wean flows because we are diuresing them the whole time. And my saying to the RTs and nurses at UCSD know is like, I diurese them until they chatter on ECMO, which means the ECMO circuit can't flow anymore because I diurese them too hard. And then I'll drop the flows and keep on diuresing them. That's how hard I diurese them. But we still need the flows to be a little over 3.5, 4 liters. And the reason is we don't want the circuit to get, clot up. Because we do very little anticoagulation in our patients to minimize bleeding. And so we still don't let the flows really get less than 3.5. So that's how we wean the VV ECMO blood flows. Weaning sweep. So now, we talked about weaning blood flows. How do you wean sweep on VV ECMO? And remember, sweep, high sweep removes more CO2, low sweep removes less CO2. So sweep is like manipulation on ECMO. When weaning sweep, we don't want them to damage their lungs. When we drop the sweep, that means we're telling the lungs, now you remove that CO2. And so when that happens, if the lungs aren't ready, the patients will start breathing harder, all right? They'll have retractions, diaphoresis, nasal flaring. Their minute ventilation will be over 10. Their blood pressure may go up. Their heart rate may go up. Those patients aren't ready, all right? And you have to back off. We wean sweep slowly, and we watch the patient. We don't want them to injure their lungs. Because if you wean sweep too quickly, you will increase their work of breathing, and that will cause high tidal volumes, all right? High transpulmonary pressures, that's a stretch across the lung, and that will cause lung injury, worsening ARDS, and barotrauma. That's why we wean sweep slowly, right? We are involved in a multi-center trial called the ECMO-free trial, talking about how you wean sweeps on ECMO. And so the study's about half complete, so you'll see a multi-center publication about this in the next probably 2 years, all right? After we come down on sweep, we do follow their ABGs, all right? Follow their ABGs just to make sure they tolerated it. But you don't need to get the ABG. You can just look at the patient. What's happening to their minute ventilation? What's happening to tidal volumes? If their tidal volumes were 4 cc's per kilo and you wean sweep and all of a sudden they're 10 cc's per kilo, they're going to damage their lungs, right? So we have to watch them closely. Same concept when you're weaning sedation and analgesia. When you wake up patients, all right, they're going to be delirious a lot of times, and their breathing, respiratory rate will go up, their tidal volumes may go up, their minute ventilation can go up, and they can harm their lungs. So you have to be careful when you're weaning sedation, all right? Obviously treat, pain, anxiety, delirium, all right? But really we wean it slowly because we don't want them to withdraw and we don't want them to re-injure their lungs. Me and a lot of other ECMO centers like Toronto, we are lung resters. There's another group of physicians that try to liberate them from the ventilator as quickly as possible, all right? And what they'll do is they put them on VV ECMO and they'll try to extubate them. The issue with that is, one is we don't know what their tidal volumes are, and so we're worried about multi-organ failure with that. And a lot of times they're very delirious from their ARDS, and extubating them is very improbable because they'll like aspirate. But some centers will try to extubate patients much quicker. All right, ventilator settings recap. All right, so ECMO for lung transplant, low tidal volume ventilation. We don't rest their lungs completely because we're going to cut out those lungs. We don't want them to injure our lungs because we don't want barotrauma. That makes it harder for them to extubate them. We do immediate PT on these patients. ARDS on ECMO, mostly for VV ECMO. We set the driving pressure. All right, we do 10, 10, 10. We may add high PEEP, paralysis, proning, INO, and we rest the lungs and then do PT. All right, VA ECMO. So VA ECMO, if you're on VA ECMO, veno-arterial ECMO, so they're in cardiac failure, all right? If they have lung injury and ARDS, we'll go back and rest their lungs, all right? If they don't, if they're on VA ECMO for just cardiac reasons, cardiovascular failure, and they have no lung injury or they just have pulmonary edema, we do low tidal volume ventilation. We do normal ventilation for these patients, all right? And this is the majority of patients on VA ECMO. This is great. We try to extubate them because their lungs aren't that bad. And if we can't extubate them, low tidal volume ventilation. We do 6 cc's per kilo. The question is, how do we titrate their PEEP? Titrating PEEP on VA ECMO is complex because it depends on the heart, all right? Not as much the lungs. If you're in LV failure, left ventricle is failing, we do higher PEEPs because that decreases pulmonary edema, decreases LV oxygen consumption, and it helps vent the LV, which we will talk about in a second, all right? Which means it gets blood out of the left ventricle, which is what we want on VA ECMO. Low PEEP with RV failure. So when you have RV failure, all right, pulmonary arterial hypertension, the PEEP increases your pulmonary vascular resistance, and that actually can harm them. We have a lot of PAH patients at UCSD, so we have to deal with this a little more. So lower PEEP with PAH patients, or best, we just extubate them. All right, so it depends, the ECMO settings on VA ECMO. So this is a tough part. On VA ECMO, how do you titrate the ventilator or the ECMO circuit sweep to the ABGs? On VV ECMO, your blood is going, on VV ECMO, you're turning blood and it's going back to a vein and it's going to the whole body. So you can check an ABG anywhere. On VA ECMO, you can't just check ABGs everywhere. It matters where you check it. And that's because of something called dual circulation. This is a complex topic, all right? And has many terms in the literature: north-south syndrome, convergence, upper body hypoxemia, Harlequin syndrome, mixing point. The new term is called VA ECMO dual circulation by ELSO, all right? What does this mean? This is a VA ECMO circuit. You drain blood from a vein, goes to a pump, oxygen, you return it to an artery. This blood, all right, now the human body, this patient right here, has 2 circuits in their body, okay? One is their native heart and lungs that's pumping blood through their lungs and heart and going out the aorta, all right? And that's going down the aorta this way. They have a second circuit, VA ECMO circuit, that's going retrograde up the aorta, all right? So where do they converge? Where do they meet? And this matters because wherever you check your ABG depends. If you check your ABG on like the lower, if you check an ABG from the femoral A line, that's telling you the ECMO circuit. But what if you check it from the right radial A line? That might tell you the ECMO circuit or it might tell you what's happening in the native heart and lungs. It all depends on where these 2 circuits meet in the body. And this is a very complex topic. There's many places that 2 circuits can meet. So on this picture, you have the heart here, the aorta coming out, going down, the blood's coming out this way, going down the aorta. And then you have an ECMO circuit draining blood from a vein, returning to a femoral artery. All right? There's many places the blood can meet. So 1, 2, 3, or 4. The bright red is the ECMO circuit, and this like blue purple is the native heart and lungs. Okay? And they're going opposite directions. As your native cardiac output increases, you move from 1 to 4 because your heart is fighting the ECMO circuit. If you increase your ECMO blood flows, they're going to increase the afterload to your heart, and it's going to push it this way. All right? Over here, this one, your heart and lungs are doing nothing. All the blood in your whole body, feeding your heart and your brain, is coming from the ECMO circuit. While 4, the mixing point is, mid-abdomen. Because the heart and lungs, the heart is fighting the ECMO circuit. And we can cause this to occur by changing the blood flows on ECMO. All right, this is why every patient on VA ECMO needs a right radial A-line. I'm going to repeat myself. Every patient on VA ECMO needs a right radial A-line. And that is because we want to know what is the blood feeding the coronaries, which is your heart, and your carotids, all right, feeding the brain. Because in reality, that's what we really care about, right? We're doing all this to feed the brain and the heart. So that's why everyone gets a right radial A-line. So that's my thing. So why do I put end-tidal CO2s on these patients? Every single VA ECMO patient gets an end-tidal CO2. Why? When someone codes and their hearts and lungs are doing nothing, no blood is going through the lungs. So when someone codes in front of you and put an end-tidal CO2 on them, the end-tidal CO2 is 0. And then when finally, the RN, nurse, whoever goes on and starts doing chest compressions, if you have an end-tidal CO2 on them, it starts going up because you're pushing blood through the heart and lungs. All right? So, this concept also occurs with ECMO. In this stage here, where ECMO circuit is doing the blood to the whole body, all the way to the heart, all right? Your end-tidal CO2 is 0 because no blood is going through your lungs. But as your heart starts recovering and fighting it off, the end-tidal CO2 goes up. Usually above 14 is the number. All right? So that's why all patients get end-tidal CO2s on ECMO, on VA ECMO. All right, case 1. We're going to have a case here. All right, so this is a patient. Their A-line tracing is this. They have good pulsatility, which means their left ventricle is pumping. Their end-tidal CO2 is 14, which means there's blood going through their lungs. You get an echo, there's good LV function and opening of the aortic valve. Great. So what number is it here of the cases? It's going to be number 3 or 4 because the heart is functioning, pumping. You can see the pulse pressure is over 10. End-tidal CO2 is over 14, which means blood's going through the lungs. That means there's good LV function, opening of the aortic valve. That means you're somewhere here. How do we change the O2 and CO2 for the brain and heart? Is it the ECMO circuit or is it your ventilator? It's the ventilator. God, I love you guys. Perfect. All right. Case 2, A-line, flat. No pulsatility. All right? End-tidal CO2 is less than 14. There's not much blood flow going through your lung. Your echo, poor LV function, not opening the aortic valve. What case are you? 1 or 2. Excellent. All right, how do you change the O2 and CO2 for the brain and heart? The ECMO circuit, the sweep and the FDO2, which is the auxiliary oxygen. All right, sometimes the A-line tracing looks like this. There's a little pulsatility, but it's not over 10. All right, so the heart's trying something. It's probably like case 2. Again, this is why every patient, the pulse ox and their A-line are always on the right hand, okay, or right ear. It's fine too. What do you think is happening to the heart in this case, in case 1 and 2? The heart cannot recover when it's not doing anything, and LV clots form. And so, if you lose pulse pressure, all right, and you become in case 1 or 2, all right, and your A-line looks like this, what do? Sometimes the ECMO flows are too high. We have to drop the ECMO flows because we're having too much of an afterload effect on the heart. We sometimes give them inotropy, so dopamine, dobutamine, norepi, epi. And then the other thing is LV vent. What we're trying to do is get blood from the LV and shoot it out because you don't want clots to form. If you're in case 1 or 2, your LV is not functioning. It's standstill almost, and it's not pushing out blood. If it's not pushing out blood, clots are forming in there, and we need to get those clots out. Or we don't want them to form anyways. If they form in there, we're kind of stuck, and we have to use intra-aortic balloon pumps. But the whole point is that we want to vent them. So why am I teaching you guys this? Because PEEP is a form of venting. You can vent patients by increasing their PEEP because PEEP pushes against the LV, helping it contract. All right? That's why I'm teaching you guys this. All right. And there's the art of medicine where we want them on a little inotropy. We drop their ECMO flows a little because we'd rather have them in case 3 or 4 than have them 1 or 2. Sometimes the heart's dead and you have no choice, and we are stuck in 1 or 2, and it's not recovering. And that's why you'll see a lot of these patients get LV vents, get the blood from inside the LV and shoot it out. And that is done by intra-aortic balloon pumps, which was the most common LV vent, but now we're moving more towards Impellas. And that prevents LV distension across the LV. The venting devices are intra-aortic balloon pump, Impella, Tandem is also one, and the last one for you guys, the ventilator, increasing the PEEP. So You guys are the RTs. You care about the CO2s and pH on these patients. So how do you change the brain and heart's CO2 and O2? If it's case 1 or 2, it is ECMO. If it's case 3 or 4, it is the ventilator. All right? And that's where you guys shine. These mixing points aren't static. Hearts may start here and improve and go here. Every time a mixing point changes, you need to get an ABG, because it may not be the ECMO circuit you have to affect. As the heart's improving, you may have to change the ventilator. On VA ECMO, remember, sweep can never go less than 0.5, because you can't, that would cause a huge shunt. You can never go sweep 0 on VA ECMO, ever. All right, final recap. VV ECMO, veno-venous ECMO for lung transplant, low time ventilation, all right? Early extubate, early tracheostomy, PT as quickly as you can. They need to walk at least 150 feet. VV ECMO for ARDS, low driving pressure ventilation, the 10-10-10. You may still do more PEEP or paralysis, proning, INO, all right? You have lower SAC goals. Rest the lungs and then wake them up and PT them. We don't know how long, no one knows. And then finally, VA ECMO with no lung issues, low time on ventilation, extubate them. The PEEP titration depends on LV or RV failure. LV failure, do higher PEEPs. RV failure, lower PEEPs, or just extubate them. VA ECMO with severe ARDS, similar strategy as VV ECMO for ARDS. We rest the lungs. But sometimes they need another venous return cannula. Lots of references. Just remember, what you guys do is super important. I'm honored to be here, but what you guys do you guys are really the MVPs. You guys are at that bedside all the time seeing these patients, and all our success is measured by the success of our patients. So, recovered, pregnant from COVID-19, transplant from COVID-19, transplant COVID-19, heart failure, got heart transplant. All these patients are ECMO survivors, and really their success is because of you guys. Thank you for everything. Please email me if you have any questions. I'm honored to be here. Thanks again, guys.